Welcome to Chapter 15, Part 2, Respiratory Emergencies. We're going to pick up with some of the causes of difficulty breathing, some of the issues that your patient might be facing. Pleural effusions. So a pleural effusion occurs when your patient has fluid in the pleural cavity on the outside of the lung. So pulmonary edema is fluid inside the lung. Pleural effusion is in that space outside of the lung. And it's going to cause the lung to be compressed, much like it would in a pneumothorax, making it hard to breathe, causing difficulty breathing. Keep in mind, most of these patients are going to want to be transported in a semi-reclined or fully seated position. Unless they are a trauma patient with difficulty breathing, you should transport them in the position of comfort. For patients who have fluid in their lungs, your CHF patients, your pulmonary edema patients, laying them flat is going to shift fluid to the top of the lungs, which is a very bad thing. But for your pleural effusion patients, understand the cause could be infection, congestive heart failure, even cancer that will cause them to get that fluid in the pleural space. And you can't forget about airway obstruction as a cause of difficulty breathing. So this could be a mechanical obstruction. It could be food or vomitus, secretions, even the tongue. And you've got to consider foreign body airway obstruction for difficulty breathing and treat it appropriately if that is the case. Kind of a picture here, two side angles, one showing the food that's stuck just at the epiglottis basically, or just below the epiglottis. And the other is showing when the tongue becomes the airway obstruction. And I think that second picture on the right side of the screen is a really good reminder about why inserting an oral airway is important in airway management. You might have a patient who has a pulmonary embolism. Remember that an embolus is anything in the circulatory system that moves to a distant site and lodges there. So an embolism is a clot. And that blood clot then becomes lodged in the lungs or in the pulmonary veins, and it causes issues associated with the flow of blood and the oxygenation of blood. If it's large enough, it can actually cause sudden death. But if you have a pulmonary embolism, it normally starts with some signs and symptoms. If it is a slow-moving or a medium-sized embolism that gets into the pulmonary structures. Signs and symptoms include difficulty breathing, sudden onset tachycardia. So tachycardia is an increase in heart rate. So tachy means very fast. Tachypnea, so tachy again means very fast. Tachypnea is fast breathing. Varying degrees of hypoxia depending on the patient. Cyanosis, because we're talking about hypoxia. Acute and sudden, so sudden onset chest pain, and blood in their sputum. So they may have kind of a pink or red tinged sputum. And those are all signs and symptoms of a potential pulmonary embolism. So another cause is going to be just hyperventilation. That is the increased respiratory rate sustained for a period of time. And when you overbreathe, your arterial carbon dioxide levels fall below normal. And then you end up having those chemoreceptors that tell you appropriate breathing rates. They end up getting all mixed up. And what it could be is that your body is trying to compensate for acidosis. And acidosis is that buildup of excessive acid in the blood or body tissues. So by hyperventilating and dropping the carbon dioxide level, it's the body's way of trying to balance it out. Problem being, you're not getting oxygen. So when you may end up throwing off the pH balance and getting a buildup of base in the body fluids. Some of the signs and symptoms of hyperventilation, which it can often be tied to a panic attack, is anxiety, dizziness, numbness, and tingling, because this is hypoxia. The longer hyperventilation goes on without treatment, the greater the lack of oxygen in the extremities is going to be. So as you get that deoxygenation, even though your patient is breathing, you're going to start to see the signs and symptoms associated with it. You can also have environmental and industrial exposures cause difficulty breathing. So that first bullet gives you a list of a bunch of different chemicals and gases that can be released into the air, causing lung damage and respiratory distress. Those have a smell, they often have a taste. There's a way to notice that they're there. Your carbon monoxide is an industrial exposure. The problem is it is colorless, odorless, and tasteless, and will impact your patient's oxygenation without them even realizing it. Carbon monoxide is produced when you have incomplete combustion. So when you've got a fuel burning appliances, smoke, you've got a furnace that is malfunctioning. And the problem with carbon monoxide is it mimics oxygen when it attaches to the red blood cells, and you get a body that thinks it has a high level of oxygenation, but in fact it doesn't. And you've got to be careful in your environmental and industrial exposures, because if your patient was exposed, you will be too. So now that we've gone over the causes, let's look at what we do and how we treat respiratory distress. And if you didn't figure it out, we're starting at scene size up. Scene size up is going to be important regardless of whether this is one of those environmental issues or whether this is a patient who's an asthmatic. Just because the medical condition isn't one that you can be exposed to doesn't mean the environment isn't going to be a problem itself. So, scene safe, appropriate BSI, appropriate PPE, understanding if it's the potential that it's an infectious disease, you maybe had to have different PPE or more PPE for. And then you've got to look at the mechanism of injury or the nature of illness. Is the difficulty breathing the result of a traumatic injury? Find out what made you call 911, determine whether you need additional assistance, whether you need ALS, whether this patient needs some sort of spinal immobilization, those types of things. Remember your primary assessment. We're going to begin with any general impression we might have, looking at the patient's level of consciousness. We're going to look at the position of the patient. Does it give you that feel that they're really having difficulty breathing? And we're going to move from there. Airway and breathing. If this was dispatched as a difficulty breathing, then you want to make sure your airway and breathing assessments are strong and that they are thorough. So you're going to, is the airway open? Yes, it is. Okay. No, it's not. Let's open it. Are they breathing? Yes, they are. Is it enough to support life? No, it's not. Then let's do something about it. Okay. Then you're going to, ask yourself, is the quality of breathing strong? Is there equal rise and fall of the chest? Is it, does it seem like there's a significant amount of work associated with the breathing? Let's put them on 15 liters non-rebreather to help them. We're going to listen to lung sounds and breath sounds. And most of the time, you're just going to listen on the front, comparing top right to top left and bottom right to bottom left. Or if you do have access to your patient's back, you can listen to the locations in the back. So top, middle, and lower. Again, comparing the same position right and left, and then moving on to the next one. You're going to listen for abnormal sounds. So you're listening for one respiration, a breath in, a breath out. Then you're going to move on to your patient's circulation check. I know it's difficulty breathing, but we check ABCs on everybody. So you are going to do a head-to-toe check to make sure there's no major bleeds, no uncontrolled and life-threatening bleeds. And then you are going to assess the capillary refill, mostly in your infants and your children. You're going to look at the skin color, temperature, and condition. Make sure that you're noting if it's anything other than normal. If you find it's flushed or cold, pale, whatever it may be. And you're going to again look for those life threats. Airway, breathing, and circulation. When there is a problem with one of them, do not go on. Treat the problem with your ABCs before you move on to the next step. Have treated your ABCs, now make your transport decision. You have to question whether this patient is a life-threatening emergency or if they are a take your time, treat them, and get them in the ambulance when you can. Remember your unstable patients, those with severe respiratory distress, those who are showing signs of shock, or they've been treated but had no relief. Those are your load and go patients. They're altered mental status. A lot of the signs and symptoms associated with difficulty breathing will likely make them a load and go patient. And because it's a medical patient, I'm going to move on to my sample. Signs and symptoms, allergies, medications, past pertinent history, last oral intake, and events leading up to. And I'm going to go into my OPQRST. Onset, provocation, quality, radiation, severity, and time. Have they taken any medication? Have they done anything to make this problem worse or better? Find those questions out. Oh, look, there we are, OPQRST. Again, onset, provocation, quality, radiation, severity, and time. I'm going to look at the acronym of PACE, or the PACE assessment. What was the progression of the difficulty breathing? Is there any associated chest pain? Is there any sputum? When they talk, does it make them tired? And exercise tolerance. All of these are related specifically to difficulty breathing. I'm going to move from the history taking into my secondary assessment. So my secondary assessment allows me to do that more in-depth assessment. I'm going to question whether or not this is difficulty breathing as the result of a medical or traumatic issue. So did they maybe hurt their chest or have traumatic injury to their chest that they forgot to mention? I might expose the area and look for any bruising or deformities, swelling, anything like that. After I've addressed any life threats, then I'm going to move on to the next stage of my assessment. I might consider signs of chronic obstructive pulmonary disease. Do they have a history? Are they a smoker? Do they have constant fatigue? Do they have accessory muscle use? I'm not diagnosing COPD, but I am considering whether or not that is a problem. And they may not have been diagnosed with it yet. Not my job to give it to them, but it is my job to consider it. And then once I've done that, remembering that my secondary assessment is likely going to be done in the back of the ambulance if my patient is a load and go, I am going to do my reassessment. Is the oxygen that I put on them doing enough? Have there been any changes in their condition? Do I need to consider a more aggressive approach to treatment? So is it time to put on the CPAP? Is the positioning of my patient supporting them appropriately? These are all things I'm going to find in my reassessment. What are my vital signs? Do I need to give them more or less oxygen? All of those things are going to be measured appropriately. I'm going to look at whether or not, instead of the CPAP, I need to get to the bag valve mask to support and assist their ventilations. If they have a metered dose inhaler because they have a history of asthma or some other lung disorder that allows them to get a prescription, can I assist them? Do they meet the signs and symptoms of that and the indications of being able to do that? And then if necessary, I'm going to call medical control. So What else can I do for my patient? Well, consider the fact that there may be some contraindications associated with assisting my patient. So, can they not inhale when you depress the medication? One of the issues with the metered dose inhaler is I need to breathe in as I squeeze the medication out. And if I can't do that, then that medication is probably not going to help me. Do they not have the prescribed inhaler? I cannot, if you go back to your rights, it's got to be the right patient. The metered dose inhaler is one of those that they must have a prescription for. So if they don't have the prescription, then it's going to be a problem. Then I have to consider whether or not they've hit the maximum dose. So again, another one of those rights. So if it's not the right dose, then I'm not going to take care of it. They're not going to get that medication. Basically, when you think about your 6 rights, when there are one of the 6 wrong or all of the 6 wrong, then you're not going to give the medication. The 6 rights must all be met in order to give that medication, regardless of what it is. In this case, it's the metered dose inhaler. What does the metered dose inhaler do? Well, what we're hoping the action will be is the relaxation of the muscles. So we are looking for it to be a bronchodilator. We want it to make the bronchioles in the bronchi bigger. Some side effects of it: an increased pulse rate, nervousness, and shaking, so muscle tremors, because it will increase the heart rate. So your inhalers, your metered dose inhaler, is a bronchodilator and a vasoconstrictor. It's going to make the circulatory system, the pipes, your blood vessels actually constrict. So increased heart rate, but a decreased breathing effort. Now let's look at treatment for specific conditions. And you can see this is slide 1 of 12. So we're going to go through some of those we talked about in part 1. If it's an upper or lower airway infection, the best thing we can do is humidified oxygen. I'm probably not going to suction the airway or place an oral airway, because that can cause those airways to further spasm and irritate them and completely close them off. So if my patient has croup or if they have epiglottitis, really, I just want to put them in the position of comfort. I'm going to consider blow-by oxygen if they seem agitated, and then I'm going to transport them rapidly to the hospital. So for your airway infections, whether it's upper or lower, my best treatment is going to be oxygen, position of comfort, and transport. If my patient has a sudden onset pulmonary edema, I'm going to consider CPAP as long as they meet the protocol indications and don't have any of the contraindications. If I can't do that, I'm going to suction, oxygen, and transport. So, the only difference between pulmonary edema and the infection is the potential to use CPAP and suction. But if that is not considered, if we can't use CPAP because they don't meet all the indications, then I am going to suction, give oxygen, put them in the position of comfort, and transport. Patient with chronic obstructive pulmonary disease, if they have a metered dose inhaler, I'm going to help them use it. I'm going to position them comfortably, and I'm going to transport. Notice this doesn't say oxygen. In reality, most of these patients are probably on home O2, and these are the patients we're going to keep at the level of oxygen they're prescribed. If they're still having difficulty breathing, you can bump it up 1 or 2. So if they're on home O2 at 4 liters nasal cannula, I would probably go 6 liters nasal cannula. But then I'm going to transport them to get them more definitive care. My asthmatics, I'm going to be prepared to suction. If they meet the criteria, I'm going to administer a prescribed inhaler, a metered dose inhaler. I'm going to assist as necessary with airway management, whether it's 100% oxygen via non-rebreather or a bag valve mask, and then I'm going to transport them. There is the potential that my patient, once given the 2 dose or the appropriate dose, so 2 puffs normally of the inhaler, still going to have difficulty breathing. So we've got to be cautious of what they call status asthmaticus, which is when basically after treatment you might get a small break in the asthma attack, but then they immediately go right back into one. So asthma, consider the metered dose inhaler, suction, oxygen, transport. Hay fever, I'd like to say you'll never get a 911 call for hay fever, but that really is not something I can guarantee. So we'll just say that you're unlikely to need emergency treatment. If they've called 911, oxygen is probably going to be your best bet just for that psychological care. Patients in anaphylaxis, we're going to make sure we remove them from the exposure to the allergen. Now, if they've ingested it, that's a whole different issue. But if it's a bee sting, if it's grass, if it's some sort of environmental allergen, we're going to remove them. We're going to maintain the airway. We're going to give them high flow oxygen. We're going to administer an epinephrine pen or EpiPen if they meet the criteria. So with your anaphylaxis, oxygen, be prepared to suction, transport, and give epi if they meet the conditions. A spontaneous pneumothorax, as an BLS provider, you can give oxygen and transport. I know, really getting touchy here and down into the weeds, but for the most part, when it comes to respiratory distress, if they cannot get a medication because it is not prescribed to them or because they don't meet the criteria, then you're going to give them oxygen and transport. Pleural effusion, I can't remove fluid from the pleural cavity. That is well outside of my scope of practice. And so I can give them oxygen, transport them in the position of comfort, and get them to the hospital. Airway obstruction, we went over this in the BLS chapter. If it's a partial obstruction, do not do the Heimlich maneuver. So if they can cough, they can talk in shortened sentences or phrases. If they are moving some air, then you give them oxygen and you transport. It is not until it becomes a complete obstruction that you clear the obstruction using the appropriate methodology, given oxygen and transport. Your pulmonary embolism, you've got to give them supplemental oxygen. And you've got to suction as needed, and you've got to transport quickly. If the hospital's aware, if you have seen the signs and symptoms, you will hear stories, and I know of one specifically, that they will get in there and get the appropriate treatment. But without quick recognition and treatment to the right facility, this patient will die. Hyperventilation. It used to be that we said, hey, breathe into a paper bag. Nuh-uh. That doesn't work the way that we used to think it did. The thought process was by rebreathing the carbon dioxide, it would balance out. Our goal is to calm them down, to support respirations. So if you remember, greater than 24, I'm going to bag them, even if they're conscious, and then transport. If you can get them to calm down, and you find that their vital signs are good, they may actually refuse. But until you get them to calm down their breathing, they probably are going to have a lot of problems. Your patient with exposure to environmental and industrial exposures, to the carbon monoxide, to all of that, big thing is decontamination. So if they've been in an environment where they have been breathing in the chemical or the gas, then the potential is that that same chemical and gas has gotten into their clothing and they're doing what we call off-gassing. So you are actually going to be exposed if you don't decon your patient. You're going to treat this patient as you would any other. You're going to monitor their airway, provide them supplemental oxygen, and transport them, suctioning as needed. Foreign body airway, foreign body aspiration, so you take a foreign body into the airway. You're going to clear the airway. You're going to give them oxygen, and you're going to transport. Your patient has a tracheostomy, so they've had that stoma, the surgical opening, and then they got a tube put into the stoma. They may end up getting an infection or an obstruction there at the tracheostomy. You're going to suction the tracheostomy if necessary. You're going to position them as they are most comfortable. You're going to provide oxygen through the tracheostomy, and you're going to transport them to the hospital. For your children who are asthmatics, they may still have an MDI. They may get prescribed a metered dose inhaler. Remember when we first talked about it, we talked about the spacer that helps them be able to take the medication. And if they do, then you want to give them the medication as they meet the criteria. And then patients who have cystic fibrosis, this is a genetic disorder that creates a buildup of mucus into the lungs. You're going to suction and oxygen as needed, but it is likely if they're having a medical emergency that the best treatment for them is going to be at the hospital. So your cystic fibrosis patients, treat as you would any other respiratory distress. If there's stuff in their mouth, suction it out, give them oxygen to support, and then get them to the hospital. And that, my folks, is where we will end chapter 15.